When we talk about treating fractures of the mandibular condyle, we're discussing a significant surgical challenge. Now, open reduction and internal fixation is the established standard of care. But the true objective isn't just about the initial alignment of the bone. It's about achieving lasting, long-term stability and function, and that remains a very complex clinical problem to solve. So after the osteosynthesis procedure, where the fractured bone is joined with hardware, a major complication can emerge. We're talking about bone resorption, right around those fixation plates and screws. What you're seeing here is a CT scan, 12 months after surgery, and it clearly shows that bone loss. This is essentially a failure to achieve that long-term stability. This investigation is all about identifying the specific variables that lead to this outcome.
To be absolutely clear, let's define what we're discussing. Bone resorption. Physiologically, this is the normal process where osteoclasts break down bone tissue. But in a surgical context like this, it signifies a pathological loss of bone volume, and it happens right at that critical interface between the implant and the host bone, which, as you can imagine, can compromise the entire surgical construct.
To really dissect this problem, we're going to turn to a clinical investigation that was published in the Journal of Functional Biomaterials. This study gives us a rigorous, quantitative analysis of these post-operative outcomes, and it provides the hard data we need to truly understand this complication. Okay, so what did this study look at? It was a retrospective analysis of 276 condylar fractures across 220 patients. All of these cases were treated by maxillofacial surgeons using open reduction and internal fixation. And the key data, the really crucial information, was pulled from CT scans taken 12 months after surgery. This allowed for a very standardized assessment of bone healing and, of course, resorption. So the real heart of this study's analysis was to identify which specific surgical variables correlate with the degree of bone loss. In other words, what choices made inside the operating room have the biggest impact a full year down the line. Well, the first significant variable they identified was the number of fixation screws used. As this graph demonstrates quite clearly, there's a distinct inverse correlation here. You can see that as the number of screws goes up, the average amount of bone resorption around them goes down, pretty significantly. The reason for this is biomechanical. It makes sense. When you use more screws, and the study suggests an optimal number is around 9, you're creating more points of fixation. This distributes the mascatory loads, the forces from chewing, much more evenly across the plate and the bone. This, in turn, reduces the peak stress on the cortex at any single point, which mitigates the stimulus for resorption. But as important as the number of screws is, it's actually secondary to a far more critical factor, and that is the precise anatomical placement of the osteosynthesis plate itself. Location is everything. Now, the data on plate placement reveals an even clearer, more direct relationship. This graph shows a steep correlation. The closer the upper rim of the plate gets to the lateral pole of the condyle, the more severe the bone resorption becomes later on. This proximity is, without a doubt, a definitive risk factor. And you can see the clinical result right here. On the left, a plate was placed too close to that lateral pole, and the result at the 12-month follow-up is significant bone loss. The stability of the fixation is compromised. Now contrast that with the image on the right. Here, an adequate distance was maintained, and you see a much more stable outcome. The investigation managed to distill this entire principle down to a single critical measurement, 14 millimeters. This right here is the key clinical takeaway. The data strongly indicates that placing the osteosynthesis hardware more than 14 millimeters away from the lateral pole effectively eliminates significant bone resorption at the site. It gives surgeons a clear, actionable guideline. And for those high fractures where achieving this distance just isn't possible, an alternative like headless compression screws should really be considered. So all these findings together really build toward a comprehensive surgical strategy. This information transforms how we think about postoperative complications. It allows us to shift the focus away from being reactive and toward proactive, predictive planning. And this allows us to directly compare a less effective strategy with an optimal one. The suboptimal approach uses too few screws and places the plate dangerously close to that lateral pole. The optimal strategy, performed by a skilled maxillofacial surgeon, uses enough screws for proper load distribution and, most critically, maintains that 14 millimeter distance. It recognizes that anatomical bone fragment reduction and precise plate fixation are like brothers in arms. One cannot succeed without the other in the war against these late complications. So, the primary conclusion of the source material is really one of empowerment for the surgeon. It states that, based on this data, it's now possible to predict bone loss. Maxillofacial surgeons can determine the ideal location and selection of plates and screws and plan the entire procedure with the goal of achieving the lowest possible rates of bone resorption. And this brings us to a final, very important question. Now that we've identified these key variables, screw number, and especially the plate's position relative to the lateral pole, can we reframe how we think about postoperative bone resorption? Is it no longer just a common, unavoidable complication, but instead a clinically preventable event through meticulous, evidence-based surgical planning?